Welcome everyone to season 2, episode 1 of Profound Conversations. My name is Karim Ali, and we're happy that you joined us today. We're very happy to bring you, another season, of Profound Conversation. I wanted to explain a little bit about what Profound Conversations actually is. Profound Conversations is a listening and discussion space which brings foremost thought leaders into a conversation to grapple with the vexing challenges of today. The Profound Conversation uses intercultural dialogue, extensive community and organizational engagement to initiate valuable cultural, educational, economic policy outcomes. In an ever-evolving world, new ideas and transformative ways of being are the lights at the end of the tunnel. Today, we are honored to have a number of guests with us from the Johns Hopkins School of Medicine and School of Public Health, Bayview Medical Center. We have a Dr. Panagis G, who is going to talk with us today regarding COVID-19, the COVID-19 update. We also have Dr. Rachel Thornton. And we have Dr. Karim Plott. She's actually in her fourth year of medical school. And we were expecting Dr. Josh Sharfstein today as well. However, he called last minute with an emergency. And so unfortunately, we won't have him today. Today, sitting in for our normal host, Linda Howard, is Mr. Andre Robinson, CEO of the Robinson Group, a community developer in the city of Baltimore. And we're so happy to have Andre today working with us on Profound Conversations. I wanted to just start out this conversation really quick with some breaking news. Heard an announcement today from Governor Hogan, the governor of the state of Maryland, regarding a new state-of-the-art rapid testing that I believe that the state is about to ink a deal with a corporation to actually produce some 250,000, they call it Veritol tests and diagnostic systems. It's called a rapid point of care antigen testing, and it promises to actually speed up as we're all used to in this virtual world, we have family that pops in and out when we least expected. So that's this virtual world. This antigen test, I'd like Dr. G to talk to us about that. The impact of actually having a test that will create the results so quickly on a number of levels. So Dr. G, can you talk to us? Had you heard about this new deal that the governor announced today? And talk to us a little bit about this rapid point of care antigen testing.
Yeah, no, thank you. So this one in particular, I've heard about trying to get more efficient testing done. So I'd have to evaluate which one specifically this one is meant to be. The one I'm probably most versed with is the one that Yale School of Public Health actually put forward with the NBA and with regards to the saliva testing. But overall, testing is key to this, right? It's key to understand where there's clusters of potential hotspots that could be going on, that we can allocate resources to mitigate the spread there. Testing to allow us to also kind of phase in, right? I mean, how great would it be to have a rapid testing where we can let family members whose loved ones are in nursing homes or in rehabilitation centers say, with this testing, yes, you can come in and see your loved ones and so forth. So, I'm excited that our governor and our government is investing in more testing. The rapidity is going to be important too. This is one of the drawbacks that I, for instance, as a lung doctor, today I saw patients both in intensive care unit and in outpatient, and the challenges about getting COVID testing are so obvious. I mean, there was 2 patients in our intensive care unit who went and got tested, and they were admitted 2 days later to the ICU, and then a week later, their test results came back. Like, I mean, by that point, like, what good is a test if it's going to take that long to come back? So If we have the ability to have an increased volume of testing where the answers can be delivered in an efficient amount of time, ideally within 48 to 72 hours, it allows the population to make public health conscious decisions in order to, either care for themselves or to recognize, okay, I'm not infected and I can continue phasing in. So long story short, I'm excited. I will look into more thoroughly at the specific tests that they're doing, but it's on par with a lot of other rapid tests that are available. The one last comment that I'll make, sometimes with the rapid testing, you do sacrifice a little bit of the sensitivity of the test with the rapidity. However, that can easily be made up if you test patients a little bit more frequently. So if it allows for that, the sensitivity that's lost is oftentimes gained from it.
Very interesting. So, Andre, I want you to jump in, but I did want to ask a follow-up question. Well, one on efficacy in terms of this new testing. Will this actually replace the molecular testing as a legacy method? And what impacts will this rapid testing have, in terms of school, for example, and business convening? Is that actually going to have a direct impact on our ability to actually send students back to school and for businesses to actually increase in terms of the convening?
Let me answer the last part first. The impact it will have on schools and businesses. I imagine it's going to have an impact, but you raise a good point. Like, who are these more abundant tests with a rapid turnaround? Who are we going to allocate them to first? My suspicion is it's probably still going to be given to populations who have been disproportionately impacted by this virus, right? Nursing homes in particular. I mean, I was in the intensive care unit in the COVID units in the spring, seeing a disproportionate impact on nursing homes, in addition to certain races and ethnicities, of course, are African Americans and Hispanic Latinos, but definitely a lot of nursing home patients. I'm in September, and I'm still seeing a disproportionate impact on nursing home residents. So my first, I love that our government here in the state of Maryland is getting a lot more of these tests. My thought is it's likely going to go to places that need more infectious control policies or more infectious control stringent implementations. And so rapid tests will help out a lot with nursing homes and so forth. So my suspicion is that. So will it help schools and businesses? It might. I just don't know if that's their immediate plan to use it in that case. So, the fact that we got the green light, we also have to cherry pick their brain and see, well, what is their intention? My immediate thought is, let's get this out to communities who've been disproportionately impacted. Same thing will go with the Hispanic Latino communities. I know you have Dr. Rachel Thornton on here. She could definitely speak to a lot of the community engagements that we often do to get the populations these testing. I mean, testing we've always emphasized as part of the key. So I'd like to say it's going to help the schools and businesses. I just can't see it immediately impacting them. Maybe in some kind of a trickle down effect, but I can't see it immediately impacting it.
Andre?
Yes, I have a sort of a broader question. I guess this is to Dr. G and Dr. Thornton, because this must be creating a little bit of a nightmare for the rest of you, that so much of what the science would have produced as a way to move forward feels to us on the outside a little blocked, because of course you've got all these other political considerations tinkering around in the medicine world where they certainly don't have any sort of standing. So it feels to me like an extraordinary amount of lack of cooperation and coordination at that level. And so I know that neither of you have like a magic wand to fix these things, but if you could suggest something to those of us on the other side who have the community side of it, if you will, not so much at our disposal, but we may have some influence there. We always see the hospital as an anchor institution partner, so that a community that has been visited with all these historical multiple morbidities over a long time, we were, I think, making a certain amount of progress, and then it stalled in the middle of this, sort of tsunami of impact hitting the entire globe at the same time. So if you could suggest anything in a post-pandemic world, and you had the magic wand, and Dr. Thorne, I'll go to you first, what would be some of the things that we could use to catch up, if you will, to make up for some of the ground that we think we've lost because of all of these machinations going on the national level?
Well, I think my colleague, Dr. Galiatsatos, referred to this in broad terms. But we're very much aware of disproportionate impacts of COVID, and I don't want to insinuate that the disparities we see today are remarkably or significantly different than the health inequities and disparities that predated the pandemic. But certainly this moment in time has brought them out of the shadows into the front of everyone's consciousness. And I think that it's a real call to action, frankly, for healthcare delivery systems, for hospitals, for everyone in the healthcare industry, frankly, to think differently about how we work together and what we should be accountable for to the communities that we serve. Another thing that I just want to pick up a thread from Dr. Galiatsatos is this idea of a system working well together so that the resource is where it needs to be to have maximum impact from a prevention standpoint. You know, a big part of that is having the testing period available, but the other piece of that is having it accessible in the places where we have a high suspicion before testing that there are risks, either in terms of how severely affected people will be if they are infected with COVID-19, but also in terms of how susceptible and at risk they are of infection. And so I think one of the other things that this pandemic is shining a light on in the US healthcare system writ large, and particularly, you know, I'm sort of like channeling Dr. Sharfstein here, bemoaning his absence, but is also that this is about the combination of public health systems and healthcare delivery. And so there, it's also kind of shown a light on the places where, you know, we think of hospitals as being the full continuum of expertise and resources to deal with health challenges. But frankly, many of these challenges start outside of healthcare delivery systems and either in the community domain or are sort of like known under the purview of public health infrastructure. And there's a real imperative here to connect public health and healthcare delivery and create more of a stickiness within the system as a result of what we're learning from the pandemic. You know, I could go into great detail, and I hope we'll get to this in a little more detail later, some of our sort of forward thinking that the Bloomberg American Health Initiative and the Hopkins Center for Health Equity are doing in partnership with IBM Watson Health to think about ways to create measures that can sort of incentivize hospitals to take on this role as a partner in promoting health across the community. But before we delve too deeply into that, I'm going to pass the baton back to Dr. Galiatsatos, who I know has done a lot of this kind of work on the ground locally in Baltimore to elevate the way we think about healthcare delivery systems and healthcare providers and the whole infrastructure as a part of communities and as having a, you know, not just, you know, we're Hopkins, we're like, both of us are in the Hopkins system. There's a lot of cachet around being part of that system in terms of the national and international stature, but we're also institutions that are intended to serve the needs of the immediate community surrounding us. So I'll stop there and pass the baton to him.
Yes, I did want to, and Dr. G, in your answer, would you also include the idea about the sort of multiple anchor institutions working together, including sometimes the only anchor institution in a lot of these communities is the faith-based community. So how do we draw all of that knowledge and power in and use it as leverage to get us to where we need to be later on?
No, Andre, great question. And Dr. Thornton, a colleague, and every time I listen to you speak, I'm like, at some point you got to campaign for presidency at some point, Dr. Thornton.
We're going to start with mayor first, okay? And then we'll work our way out together.
Fair enough.
No politics here, no politics here.
So the first thing I want to make clear is, you know, 2 points that may seem obvious, and but I'll just share them to have them out there. That medicine and health are not synonymous. You know, health for the community can mean anything from jobs to, having your grandkids over, right? It's just a purpose of well-being and a purpose overall. And then the other component of this is, hospitals specifically, right? We have such little to do with regards to certain variables that impact health outcomes, from housing to transportation to neighborhood quality. But at the same time, while these impact health, hospitals are always the first to be blamed for poor health outcomes of a community.
Right.
And I say this because we have to engage with the community to promote health and prevent disease. And I think hospitals are recognizing more and more that if we are really to make the biggest impact of health, it's not going to happen within the confines of the four walls of a hospital. So those two notions out there, I think a hospital, especially the ones here in Baltimore, Hopkins in particular, both on Broadway and on Eastern Avenue, we've begun, to change that tune, to recognize that, community engagement is part of the strategy of public health outcomes. And then COVID hit, right? And I think it's resulted in a massive catalyst to expedite this. The reason for it is, what are we asking people to do to battle COVID is to just not get it. So you're saying physical distancing, you're saying hand hygiene, masks, quarantine, let's get you resources. All of that is on the shoulders of the responsibility of the community. There's no way a hospital can impact that many lives.
Right.
So you're right, we're going to have to rely on who are the pillars in the community that we can turn to. And from my standpoint, and Dr. Thornton's work in the community as well, we recognize, housing units are great, but oftentimes the challenge, there's pros and cons, right? The challenge sometimes with working with housing units is there isn't a really unified community leader that people turn to. Schools is another one. Good reach to certain communities, but leadership oftentimes is challenging there. This is why we love working with faith-based organizations. We're asked to get a sense of community right off the bat. Oftentimes because of the culture and the faith that people are part of, almost a weekly gathering of adults, that's great, who all have an innate sense of wanting to help one another. And the leadership there is key. I cannot emphasize that enough. When you work with these leaders, from imams to rabbis to priests to reverends, when he or she understands that message, and more importantly, can translate it into what the community will gravitate to, right? We want to stop COVID-19. The translation there might be, we want to keep people safe. They're on my standpoint, they're on par with two public health outcomes discussed in two different ways, from community health and population health. So I agree, Andre, if we're going to make an impact, if we can, moving forward, kind of in a transformative way of medicine, from my standpoint, let's find some silver lining in this pandemic, so these lives lost won't be for nothing. These lives that have been changed forever won't be for nothing. And if we can redefine what a hospital means in the 21st century, that could be a massive win for this. And it's needed. You were seeing this right now in the pandemic. We need these redefinitions. So I love working with faith-based organizations. And so the last part I'll add to this, and I'll stop for more questions, is that especially your listeners who are listening or watching this later, this will mean, think about what these congregations can begin to do, right? We hold community calls twice a week with a lot of faith-based leaders. We call them the community calls, right? Because they're telephone calls, but also it's the call from the community. And we make it clear, have these, congregant individuals rise up and be the COVID leaders right now, right? So if they need to phase in their congregations, they can work with us in order to do that appropriately. Later tonight, we're going to be talking to a synagogue about how to phase in for the Jewish holidays that are coming up. So I think this is a great time where we all can kind of reassess, or what does a hospital mean in the 21st century? What does a faith-based organization mean in the 21st century? It could all become these transformative roles to evolve, to promote health and prevent disease in the maximal effort.
Great question. Great answer. Thank you very much for that. And I'm going to get, am I allowed to call you Dr. Plott yet? Are you at that, you're in between, or can I call you Dr. Plott?
Yeah, or you can just call me Kara. I'm a medical
Okay, I'll just call you Kara for right now. You'll let us know when you come all the way. Your particular specialty in nutrition is actually also one of those morbidities that we're already addressed with the lack of healthy food in communities, lack of access to healthy foods that sometimes are tied to cultural norms, right? That that eclipse the good sense that we need to implement. Sorry, the device is tied to my telephone, so sometimes it cuts me off. So are you able to see any advancements, if you will, on the understanding about the impact that solid nutrition has when the hospital actually, the doctor in particular, can't do anything about the access to available food that's available in a lot of the communities around the institution?
Yeah, I mean, I think that, food choices are so often rooted in access, and that is rooted in community investment. And our country has systemically chosen to not invest in several communities, including those of African American, Hispanic communities, low income communities, and that has created something that some people call food apartheid, which essentially is also called food deserts, although I don't usually use that term because I think it kind of connotates there's something wrong with the community, but
Sure.
Of course it's really
the latter is
rooted,
actually more accurate. Actually, the food apartheid is actually more accurate.
right. And I think too often the conversation goes to the choices that individuals make, but there's this larger infrastructure that is impacting the ability to even make a choice. And a lot of us, myself included, are privileged to not have to be in a situation where we don't have a choice, but many individuals do not have that choice. And so I think it's important to continue to advocate for investment in local grocery stores, especially supporting those smaller businesses during this time, and understanding how we can other ways in which to provide helpful, health promoting food to the communities, and instead of having any blame or judgment on the individual, thinking about the large scale system that's leading to these inequities.
Great. Karim, did you have a follow-up?
Yes, I did. I didn't want us to step over a lot of the great work that Dr. G and his team has been doing probably for better than 6 months consistently, at least twice a week. The COVID-19 Community Partners Call. I believe they're on Mondays and Fridays, and I wanted to bring attention to that. And I believe that we'll have the link to that phone call in our chat box. But I mean, over the weeks, you've brought doctors to discuss ailments of the heart, safe schools, post symptoms of COVID-19, healthy community partnerships, ophthalmology, and safe schools, geriatric medicine. Tell us a little bit about the genesis of that community call and what you've seen as the impact over the weeks and months that you all and your team have been doing this work.
Always got to make sure that you're not muted in this Zoom world. So I love that question because, one of the things that you recognize when you work with a community, when you get to, you may not be able to be in their shoes, but if you walk by them, side by side and understanding their day-to-day struggles, you're going to hear a lot. And so March 13th, that was a Friday here, and well, it's a Friday throughout the world, but March 13th is when Governor Hogan of the state of Maryland revealed, hey, we're going to go into lockdown. Schools, everyone, so forth, stay at home. It's Saturday morning from one of our community partners, Mark Carter, he calls me. It's about 7:30 in the morning. I see a call from him, something's going on, so I pick up the phone. And he made it clear there's two concerns he had. One, this is going to affect African Americans more than anyone else. He's like, they already have high rates in my community of intensive care unit visits from infections and so forth. It's going to ravage us. And two, he's like, all I heard from the governor was we're going to need more testing and ultimately vaccine. He's like, who is going to trust these institutions to do testing? He's like, you can't come at this in an ahistorical way. Like, medicine's trust has been broken countless times for certain populations. And suddenly with this pandemic and wanting to do the things that caused the mistrust in the past, we can't turn this new chapter without recognizing the priors. And my heart sank. I mean, he was spot on. I mean, everything he was predicting over the phone, I mean, it has come to fruition, sadly. And so I say this because I called my colleagues at Bayview and I was like, the community is going to struggle with this. I mean, especially certain populations. And I know like Dr. Thornton and student Dr. Plott, like we recognize this. Like, I mean, when you're out in the community, you know this pandemic, you know, before it even made its way for the first case in Baltimore City on March 14th, you knew it was going to impact disproportionately certain populations. And so, you know, what came of that was, let's just start off with one simple task. Because up until that point, another part that was making a lot of physicians and scientists and nurses and public health officials pull their hair was just an inconsistency on messaging. You know, you had the World Health Organization talk about how bad this is going to be. You had Italy, you had physicians from Italy being like, we are ravaged by this here. You know, the same thing out of China and so forth. And then you had inconsistent messaging here in our state. So we said the first thing we can do, while it may seem like low-hanging fruit, but at least let's start here, was let's set up calls where our own partners that we formed over the last decade, they can call in and we can give them the most updated messaging about COVID-19 and what they can do. Right, from our standpoint, can we provide a sense of hope in a time of hopelessness and a sense of power in a time of many feel powerless. And we started off, like, I will never forget, we sent an email that Monday morning. So now we're March 16th, right? We sent it off to our 80, congregations and so forth. We had a call at 3 o'clock, and I promise you, when that call ended, I was certain there was like 6 people on that phone, because I heard 2 community members and then my colleagues were the other 4. But we found out there was 125. Then Friday's call, we got to 175. You know, by the following week, we were at 200, and now we're still averaging about 80 people on these calls. And I say this because it clearly showcases that the community is hungry for consistent messaging from a trusted source that is actionable. It's not just, it's bad, COVID is here, but what can they begin to do? Like, every physician, every healthcare professional that comes on these calls, we make it clear, like, we're gonna make this into a Q&A, but we gotta provide some information that they can act on. And so, yeah, no, that's what we've been doing for the last 6 months, feels like forever. But the point I wanna make an emphasis here, we discussed earlier, so much social reengineering has to happen to stop the spread of this virus. And so that, to me, like, let's use that, let's turn the tables on this virus. Let's try to empower as much as we can the populations who've been ravaged by this, get them the information, get them the resources. I mean, that's what we've been trying to do with these calls. And from these calls, we've helped congregations with phasing in. We started a curriculum for the schools. Like, it's, the community has our heart, and people like Dr. Thornton and student Dr. Plott, I mean, like, that's what we know this because you tell us this. You tell us how important it is to work with the community.
Excellent. Yeah, I wanted to just let you know, we're going to open up the phone lines or the internet lines, if you will, at about 4:45 for any questions as we begin to close out at that time. Something you said earlier about redefining what hospitals actually mean in the 21st century, and it sort of brings me to the work that Kara and Dr. Thornton are actually involved in. It's a proposal currently measuring hospital contributions to our community health and equity. So I wanted to give them the floor to talk a little bit about that proposal and what you see actually coming from that. And we can go a little bit deeper in as much as Andre Robinson is a community developer, and I'm certain that he's got a lot more that he'd like to add to that conversation. So Dr. Thornton, did you want to lead off on that survey, that current survey?
Sure. Thank you so much for the opportunity, Karim. I think it is essential to get feedback from organizations like yours, from the faith-based community on this concept. And frankly, I think there's no better time to introduce it than in the context of the pandemic, as I was saying earlier. And really the idea here is so there are a variety of different ways that hospitals get ranked in terms of their quality or their performance. And the Bloomberg American Health Initiative, led by Dr. Josh Sharfstein, and the Center for Health Equity, led by Dr. Lisa Cooper, with me as the lead from the center for this particular project, are partnering with IBM Watson Health in reimagining how they can hold hospitals accountable and incentivize hospitals to invest in community health and equity on par with the investments they make in healthcare quality and patient experience. And so the idea behind this proposal is to really use evidence to inform the development of an additional measure to be counted on par with the other measures in this ranking system that IBM Watson Health stewards call the 100 top hospitals ranking. And really, we are coming from the standpoint of what Dr. Galiatsatos mentioned earlier, which is this notion that health is more than access to healthcare or delivery of healthcare. Our premise is that healthcare needs to be delivered equitably, effectively, and appropriately, and it needs to be accessible in a just way. But hospitals are also a major economic engine in many communities. The healthcare sector, the healthcare industry is contributes significantly to government spending and sucks up a lot of economic resources in communities. And so the idea here is to propose measures and performance measures that reflect a hospital's commitment to investing in the community where it's located. So there are 4 components that we're proposing as part of this measure, which I just want to rattle off quickly, and hopefully the participants on this conversation will have questions and comments for us, as well as yourself and Andre, because we really want to hear how to improve our proposal. But the 4 components of the measure are holding hospitals accountable for population health outcomes, and here we would be assessing the progress in decennial trends, so trends over a 10-year period in life expectancy and in preventable hospitalizations in the county where the hospital is located. We would be providing them opportunities in component number 2 to report on their role as a healthcare provider in promoting community health. And in this space, we've identified best practices like offering smoking cessation services and treatments to every patient who enters the hospital, for whatever diagnosis they're presenting with. Things like being a baby-friendly hospital, doing appropriate screening for intimate partner violence, and a variety of other things. In the 3rd component, this is really about the hospital as a community partner. And here, we're talking about the ways that hospitals partner with other organizations in their community outside of what they do within the walls of the hospital. So to some of Kara's earlier comments, this would be a place where a hospital could partner and meaningfully invest in improving access to healthy foods in the neighborhood. To Andre's expertise, this is a place where hospitals could contribute meaningful investments to affordable housing, quality affordable housing in their communities, to community development, to supportive services and supportive housing in their communities. And so we've given examples of all of these things. I think Kara may have already chatted some information about the proposal into the chat, but if not, I think she will do so momentarily, both a link to the proposal itself and a brief explanation of the proposal, and then also opportunities to comment either by completing a survey that's available online or simply by emailing us at hospitalmeasure@jhu.edu. And then the 4th component of the measure that we're proposing is around this idea of hospitals as anchor institutions. And frankly, I think this is where reversing some of those structural inequities that hospitals as institutions have contributed to over time is potentially on the table. So this is where hospitals can demonstrate their commitment to equity and to community health by having demonstrated plans for improving the diversity in representation in the board, the board of trustees of the hospital, in the C-suite positions and top-level management positions within the hospital, in demonstrating that they're committed to procurement practices that would prioritize investing in local businesses and minority-owned businesses in their community, in making commitments to provide compensation that is aligned with living wage metrics in their geography, providing access to affordable quality childcare for their employees. If COVID has done nothing else, it's shown a light on all of the essential workers, the healthcare workforce, who themselves are food insecure, housing insecure, economically and financially struggling. And then in this anchor institution domain, we've also highlighted things like paid sick leave, again, something that is essential here in the context of the pandemic, but there's a significant evidence base to support its value to community health otherwise. And then things like do no harm collection policies. So in all four of these domains, we have highlighted examples that some hospitals and health systems are already implementing that are based on the research evidence around the social factors and the intervention approaches that positively contribute to community health, and frankly, in many instances also are designed to combat inequities and health disparities. So I've sped through a lot of information there, but I think the idea is to open this up to the floor. I will say, and I would love particular engagement to the extent that people are interested from your constituencies, is ways that we can think about further demonstrating through best practice examples what community faith-based partnerships with hospitals and health systems look like and the essential role that those play. I think Dr. Galiatsatos made a really incredibly important point, which is, hospitals are not always trusted sources for every community for good information. They're not always seen as, without some accountability for the ills and the wrongs of the past, which is something that I think Hopkins as an institution continues to work to reckon with itself. But this idea of engaging people who do have trust, who are embedded and committed to the spiritual health, the physical health, the mental health, every aspect of health and well-being of their faith communities, and what those partnerships might also look like. So our proposal is really a framework. We sort of demonstrate in the proposal what we think, the criteria will need to be for each of these measures. They have to be largely transparently reportable and relatively easily reportable by the hospitals and the health systems in submitting questionnaires for consideration in this ranking system. But I think that also provides an opportunity for community partners to weigh in and say, yeah, this is really an accurate depiction of their engagement as a community, as a partner with the community, or to the contrary. And so, so we hope this opens a conversation. We think in addition to informing the ranking system, that this is also a way to inform the broader community of some of the best practices that are already out there and recommended either by, healthcare subspecialties, by public health departments, by, other sectors like housing and community development sectors, and sort of raise the game for every hospital and health system out there. So I'll stop there. I don't know, Kara, if there's any finer points you want to pull out, and then I'll pass the mic back to Karim to keep us on track here with the conversation. But I think we're very, very interested in your thoughts and your feedback, both now and once you have a little more time, for folks on the line who are hearing about this for the first time to process the information in more detail.
Thank you, Dr. Sword. Dr. Plott?
That was a wonderful summary. Thank you. No, I don't have anything to add. I'm eager to hear your thoughts.
Corinne?
Well, no, one of the things that actually came up for me as a question was, are there currently any working models of the hospital community collaboration that perhaps need to be expanded and funded?
Yes, so I think we identify a variety of models in our report from around the country. We try to be, in our proposal, we try to be comprehensive about what hospitals in different places are doing. I see Dr. Galiatsatos also wanting to make a comment here. I think, in the housing space is one example. We hold up Bon Secours here in Maryland and some of the work that they've been doing to invest in a way that is focused on the interests of the communities. I think, the housing constituencies that we've heard from so far agree with us that that is one example of a good model for a hospital as a community partner. And then Nationwide Children's Hospital is another example that is doing a lot of innovative work around community development and affordable housing access and expansion. Again, I think, part of the challenge here is that hospitals oftentimes have a lion's share of resources in proportion to some of the other essential safety net services that people need. And so the idea is not for the hospital to usurp the expertise of other sectors, but really to effectively and meaningfully partner with people who do have the right expertise to address some of the social factors that are fundamental to health inequities.
And just to go off of what Dr. Thornton amazingly spelled out, without hinting at an example, I just want to, more of a general concept, we redefining the hospital, and it's been emphasized, but when we target these health goals that we recognize they're in alignment with a population health strategy for a public health outcome, if we can do it in accordance with a community health interest, we will have such an impact. And that's what Dr. Thornton was emphasizing, right? Housing, we know stable housing promotes a lot of wellness and can prevent a lot of morbidity and disease. So we have to recognize this. And two examples I want to provide is one, working with Southern Baptist, a congregation in Baltimore City behind Hopkins Hospital. Their senior center was, while it was being constructed, was burned down during the Freddie Gray uprising. And I see this because we partnered with their reverend, who's now a bishop, and we worked with him. And I'll never forget a very key example when we wanted to do, for instance, flu vaccines for the community. And, one of these community members was just like, we have so many other things concerned about, and we were like, well, tell us. And I just remember them telling us like jobs, like the community is struggling to find jobs and so forth. And there's the community health interest. What we ended up doing was giving a minor presentation a week later when we were, for the weekly meetings. And we talked about how, flu vaccines have been shown to prevent school missed days, as well as adult missed days of work. And when the community heard that, they're like, you get it. Like if our kids miss a day of school, then we have to miss a day of work. If we miss a day of work, then, we're not going to get our paycheck. So I say this because when we work with the community, these models are great, but at the end of it, we have to make sure that the community's health interests are in alignment with the population health strategies the hospital is trying to achieve. When you have that amazing relationship where the hospital seems like it's working for the community, then you're going to get the biggest impact. So all the examples Dr. Thornton laid out, those are key examples, but at the heart of them, it's that alignment. That's the emphasis. That's what needs to be recognized.
Right.
Back to you guys.
Oh, no, that was really good. I was also interested in understanding are there models of how you actually connect with the community? I mean, do you have a current, a deep discussion forums or, listening sessions where you're actually hearing the voice of the community to really understand, what's there for them and in their minds, what would actually be the redefining, of hospitals as supporters of the community?
Yeah, I think Dr. Thornton and I are really well positioned to answer this, but I'm going to answer it as if there wasn't a pandemic, because we're trying to figure out what community engagement looks like in a time of a pandemic at the same time. But I see this because the simple answer is you got to go to them. Yeah, we can hold listening. There's nothing, I'm not trying to take anything away from them. Those are all important, but at the end of the day, you got to go to them. I was interviewed a few years back with Reverend King. He's a local reverend, but he runs this fantastic marching band called Christian Warriors out of Poe Homes, a home out of West Baltimore. And I just remember the reporter asked him, like, why work with, Dr. G's group? And he said, he responded in it, which seemed so simple at the time, but was, as to me, like, that's the bedrock. He's like, they just show up. He's like, you got to show up. If you don't show up, why would we work with you? And that has always stuck with me. So yes, whatever label you want to present it, listening session, just show up. Like, that's it. Like I said this in the beginning, we can't be in their shoes, but you gotta walk with them. And so that's the key. Whatever you want to label it, fine, but just show up. Dr. Thornton, yeah, your thoughts?
Yeah, no, I think, and I'm just looking at some of the comments in the chat as well. I think that showing up, but also like inviting those voices that even within community organizations that may not always come to the fore. And I think that we are, one of my hats is as a researcher, and in the research community, there has been growing imperatives to, to be able to demonstrate that the things we're studying, the interventions we're testing out, have been kind of gut checked, validated, are consistent with the priorities of communities. And I think a big part of that actually is the listening, Karim, and ensuring that people feel heard in that process. And one thing I will say in our work, and admittedly it is sort of a couple levels above the level of grassroots community engagement, but in this proposal, I think another way of doing that is connecting across sectors with the organizations that really are working on the priority issues in different places. Sometimes what happens with health and healthcare is we just kind of come in and take over. Like, you can't have anything without health. And, but health may be having a job or having self-determination or freedom. It may really be about some other fundamental value that is more important than, a blood pressure measurement. And so I do think another way of approaching it is to think about, connecting health to people's everyday lives, and making it tangible in the context of things like work, like education. And so in that regard, I think part of what we're doing is demonstrating best practices that cross those divides, almost more for the consumption of the hospital and health system constituencies in some regards than for, communities. I think it's intuitive to us all as members of the communities we're a part of that, if I don't have a job, if I don't feel like I can do what I need to do for my family, if I don't have a place to lay my head every night that feels safe and secure and, and affordable and healthy, what kind of health could I possibly have? So I think part of this is about getting away from, those biological measures of health that tend to consume a lot of attention in the healthcare community to some of these fundamental contributors and factors, and both through outreach to other sectors, but then I think also through a more inclusive approach of engaging communities and describing what their priorities are, and giving those more weight than potentially, what the health insurance companies want to pay us for in terms of population health performance. And I might get in trouble for saying that, but fundamentally, I think that's a big part of what this is about.
Yeah, and Andre, I wanted you to pick up on this thread, and thank you, Dr. Thornton, for that. I had asked you earlier if you had read Samira Fazli's work. She's actually with the Federal Reserve Bank of Atlanta, and that she wrote a few papers, regarding hospitals as anchor institutions and these opportunities to actually collaborate and create impact in this way. Specifically, one of the papers that she wrote is entitled Anchor Institution Strategies in the Southeast, Working with Hospitals and Universities to Support Inclusive Growth. I wanted Andre to dig a little bit deeper as a community developer and having experience in the development area. How is it that we can actually make progress in terms of creating these collaborations in these cohorts to actually move projects from our planning and from our proposals to actually digging in the ground and getting things done in the community?
That's always the $64 million question, right? We have Baltimore is a great place to see the preponderance of the knowledge economy that's here, right? We have an extraordinary output of intellectual capacity here. What we're also able to observe pretty quickly is where that fails on the implementation side. So I think that one of the things that we could learn from this particular moment that we're in is that to a certain extent, culture trumps policy, right? Forgive the old word, I didn't invent that, Trump was already in there. But certainly that, you know, we have a preponderance of philanthropic organizations. We have these wonderful institutions here, all with wonderful mission statements on the wall. The challenge comes when you step outside of that institution and you're in this sort of deep and murky, almost a poison sea of these historical structural issues that the hospital alone does not have the power to do anything about. So to a hammer, of course, everything looks like a nail, right? So I'm a housing guy and I'm a workforce development guy and a business development person. And so all those ecosystems around the hospital, which also, of course, has to be, what has to be included there is the impact on people's mental health. That if I'm hiring people that are not healthy enough to stay in that job, they won't have that job for long. And if in fact you are underpaying that person while they're trying to feed a family of 4, 5, or 6, and we found that looking at the Philadelphia row home strategy, that after asthma, the #1 thing that impacts on hospital visits is falls. So most of our hospitals are surrounded by almost 100-year-old housing, much of which is in desperately poor repair because of redlining, all the issues that tie to that. And the hospital does not have the engine to do something about all of those things. So you really need the hospital, the builder, the school, the political structure to be in sort of accord with each other, and they're not always. Different seasons, different policy impacts, different rules. And so those of us that are on the outside as community developers have to look at all those conditions and rely on first leadership to do something beyond just stating wonderful things and pulling from this phenomenal research to say, therefore we shall do what and in what order. And sometimes those priorities will be competing. And so I think that what we're looking for in this post-pandemic world is really a commitment and resiliency on the part of the institution, which may have some complicity in those practices of the past, right? You pull these threads at any of these hospitals and you're going to quickly come to policies that should embarrass the institution. All the way down to the bedside manner that is not always conveyed to populations of different ethnic mixes in the same way. But if you're not resilient in that conversation when you face that thing, then you're going to back away from who wants to continue to be blamed for something that happened in 1955, right? But to be robust in your ability to look at those things and address them. So if I'm trying to mitigate a building that has fallen down, I can't just slap a bunch of shiny stuff on top of that broken foundation. You have to excavate, you've got to get it out, you've got to clear it all out and start all over. And I think that's also going to be the case with life after this pandemic. We're not going to be able to do very much about the multiple morbidities striking communities that are filthy, that are indeed rat and roach infested, that are falling apart and that are harming the very people that live in those communities. So we think that housing has an outsized impact on the health of those people going to work, and then when they're going to the hospital, they're not coming when they're already at stage 4, right? They're going to come when they are actually adopting some of the policies and practices that Dr. Plott is talking about. Am I eating my cancer? Is my house actually making me sick? And those practice communities and that sort of knowledge commons that we have here in Baltimore coming together, I think would make Baltimore one of the most attractive cities in America, because there's just enough housing available. And we have to break the sort of racial tie that says that affordable means for Black people, because your researcher who is got a $75,000 student debt load needs an affordable housing platform. They're not. I don't see very many medical students coming out and lighting cigars with $100 bills. So I think that there's a broader context that's available to us now, particularly here in this city that's known as an eds and meds town, and that's very, very true. to look at all of those things. Now, I'm not saying who's responsible for pulling all those things together. I think we all have a role in that regard, but I think that the builders and the planners and the researchers and the political structure could be taking better advantage of the things that we know and moving us all to at least the 27 priorities that say that this is the way that you actually build the community's health up. And actually, we have found in the social determinants of health business that the same determinants of health are those the same as wealth. It doesn't really matter how much money I have. If I approach stage 4, all my money is going to go to that. And so I think that's really the opportunity that we have with all of this great stuff that we have here available to us in Baltimore to implement strategies that pull communities out of this historical morass that they're in. And as we build it, the house has to have telehealth in it, and the communities have to have ease of access to certain things. And we look at all of those conditions without being overwhelmed by the enormity of it. So I know that's asking a whole lot, and I know nobody has the sort of magic bullet on this, but I think that in some of this research that we can pull from it, no, I'm supposed to be asking a question here, but I'm making a statement, that we can pull from some of that research and really pull the things at the top of the strategy that say that these are the things that we must do, and we must do them right away. And here comes COVID to force us to do it right now, or otherwise we know that it doesn't end with the discovery of a vaccine. There's going to be years and years of this thing grinding to a halt over time, and to look at the other things that will actually impact on it and intersect with it that will maintain these communities in very poor health. So I'm excited to tackle the work of that. But you know, we can finish a house in about 6 months, but it doesn't necessarily mean the person moving in that will be able to be there 2 years from now if they don't have a job, are in poor mental or physical health, their children are not able to compete in the modern age where everybody was sent home, but I'm loaning Wi-Fi to my next door neighbors for them to do their homework, and that doesn't go very far. So
I just want to
pull all those things in.
I want to thank you for that. We're coming to a close of the time. What I do here before I actually read the acknowledgments, and we want to let everyone jump off on time, is that it sounds like there's an openness for ideas coming from the university. There's openness to actually have deeper listening sessions with the community and the creation of collaborations and cohorts. I want to thank Dr. Panagis G, and I'm sorry I don't pronounce your last name as fluently as Dr. Thornton. Thank you, Dr. Thornton. And thank you, Kara, Dr. Plott, for joining us today. I want to thank Andre Robinson for filling in for Linda Howard today, and I've got some other acknowledgments that I'd like to read, and I promise you it'll take no longer than 30 seconds. Profound Conversations is executive produced by the MLPI executive team, Samuel Sharif, Linda Howard, and myself, Karim Ali. Programming is written and produced by Mr. Samuel Sharif and the Aliyah Network. Webinar Technical Logistics is produced by Erica Christie, Khadija Ali. Today's host, again, was Andre Robinson, the CEO of the Robinson Group. Am I correct on that? The Robinson Group? Community developers. Our guests were Dr. Josh Sharfstein, Dr. Panagis G, Dr. Rachel Thornton, and Dr. Caroline Plott. Without the support from these individuals and institutions, our program would not be possible. Special acknowledgments to Kimberly Munson from the Community Program Coordinator, John Hopkins Bayview Medical Center, John Hopkins Bloomberg School of Public Health, and colleagues at the Henry Ford Hospital System who are actually in attendance today. And a special shout out to a good friend, Ms. Kelly Ranham, hailing from Louisiana, the Louisiana Organ Procurement Organization. Again, my name is Karim Ali. I'd like to thank you for coming to our season opener of Profound Conversations. And we look forward to seeing you next week and the coming weeks for our programming. Thank you so much.
Thank you for the platform.